Welcome to Gosfield and Shay on Health Law.
Hey everyone, welcome back to an all-new episode of Gosfield and Shay on Health Law with Alice Gosfield. I am your host, Mike Leon. You know, Alice here is a nationally recognized healthcare attorney who has spent her entire legal career advising physicians on Medicare, fraud and abuse, Stark law, and value-based payment. And she's known for her strategic clarity, prolific writing, and deep influence on federal healthcare policy. Apropos, because in today's episode, Alice is going to break down the issues and potential pitfalls out there in billing for non-face-to-face services with respect to Medicare. Alice, it's good to see you as always. You know, I was telling you this off air, and I'll ask it here because you've noted that the reports of the demise of the fee-for-service are a little premature, but that Medicare is increasingly paying for the coordination without a visit. Explain that for audience, but also how does this shift kind of fundamentally change the risk that kind of profiles in physician employment agreements?
Codes that are developed for non-face-to-face services are paid on the physician fee schedule on a fee-for-service basis, but they have specific documentation requirements that are associated with them. Some of them have time-based aspects to them. And so in the physician employment agreement, in much the same way that you want to require that the employee follows your compliance program and follows your documentation guidelines, you may also want to put in a provision that says that they will undergo training if you're going to have them build these codes so that they learn how to do it effectively and that it's part of their compliance obligation to do it the right way.
Speaking of the codes, what kind of specific red flags are the federal auditors out there? What are they looking for in these non-face-to-face documentation that maybe they weren't tracking, let's say like 5 years ago?
So some of these non-face-to-face services go back to the inception of the program practically. Incident 2 is a concept that any physician practice knows about, although it still creates liability for lots and lots of people. And it came with the inception of the Medicare program. Care plan oversight, which is really where you're looking at what's happening to the patient, but you're not seeing the patient, also goes back a good period of time. The OIG has issued multiple reports, both on care plan oversight in 2005, Incident 2 in 2009, and then on the newer codes, there's an OIG report on chronic care management in 2019, transitional care management in 2021, remote patient monitoring in 2024. All of these reports identified a host of problems, many of which included billing for multiples of these non-face-to-face services in the same time period. Some can be billed together, some cannot be billed together. And so that was a problem. Billing for complex and non-complex chronic care management in the same 30-day period was another example of problems. And remote patient monitoring, which has grown exponentially. I'm talking like 10 times more volume of the performance of that service, had patients that didn't receive all the components of the service. So those are the kinds of things that the OIG is looking at and has demonstrated a keen interest in.
Can you expand on the last part with respect to RPM that you were just mentioning? Like, how does that inadvertently trigger a quality fraud investigation, especially if the clinical outcomes kind of don't match, you know, the time that was billed?
Well, RPM is a process of remote physiologic monitoring. So the patient has to have some kind of a device that is reporting data on a remote basis back to the physician who analyzes the data. The outcomes is not necessarily what the issue is. The question is whether the service was provided in the totality of the components of what needs to be done in the service. You can use clinical staff, which is not very well defined in the system, to do part of it, but not every element of the service. And these are where the pitfalls come in.
Well, speaking of those pitfalls, how are the rules, you know, kind of clashing with the remote, decentralized nature of the modern non-face-to-face services? Like, how is this all brushing up against each other?
Well, this is part of it is a manifestation of the advent of technology, making it possible for remote physiologic monitoring, which was not available before. So in a sense, the remote physiologic monitoring, chronic care management. These are services are primarily going on looking at data that you have available in medical records, writing orders as a result of those data, sometimes talking to other clinicians, but it doesn't involve seeing the patient face to face. I think the way to think of it is that it's just an extension based on technology of the basic principles of billing under Medicare.
Let me ask you something on billing. You just mentioned billing. Under the rules for split shared visits, like how should the determination of the billing provider be made?
So the principle of split shared visits is that both a non-physician practitioner and a physician are seeing the patient in some quantum of services shared among them. So the definition of who gets to be or has to be the billing provider turns on who did the substantive portion of the visit. That has a specific definition that I want to read to you. The substantive portion means more than half of the total time spent by the physician and non-physician practitioner performing the split or shared visit, or a substantive part of the medical decision-making, except as otherwise provided. It can include preparing to see the patient, reviewing test results, discussing the case with other clinicians. Let's focus on medical decision-making, which is the other part that can determine who's going to be billing for the service. And the definition of that is establishing diagnoses, assessing the status of a condition, and or selecting a treatment option. So when the two clinicians are engaged in these activities, they need to pay attention to documenting who's doing each one of those things and for how much time.
So, Alice, how do non-face-to-face service revenues, how does that kind of complicate the volume or maybe the value prohibition in the anti-kickback statute? Especially, to my understanding, physicians are compensated based on coordination of care that they oversee, but sometimes they don't personally perform.
So both under the Stark statute, which is a Medicare and Medicaid only statute, and anti-kickback, which is far broader than that, physicians who are referring to entities that they have financial relationships with because they get paid for doing services for those entities cannot be paid based on volume or value of the services they perform. By contrast, physicians in their own practices can definitely be paid on the productivity, which is the volume or value of what they literally perform. The way these codes are described, they are attributed to the physician, even though the physician is not doing most of what it is that's going on. It's the physician's service that is being billed. So they can get allocated that, and it can be included in their compensation.
So on that front, how can these physician groups kind of restructure their comp models to reward the care coordination?
So if they really want to emphasize the care coordination, they can compensate for those codes at a higher rate than what they code for generally. Usually in a physician practice, the physician gets a portion of what the revenues are that are generated. Some get paid 50% of their productivity, some get a base, and then they get 70% of their productivity. But productivity is a very common model, despite all of the hue and cry around value-based payment. And so if they wanted to make people do more of this, they could incentivize it by paying more for those codes or setting targets for those codes within their compensation models, even though they literally did not perform all the service themselves. I kind of think of it as incident two on steroids.
Well, Alice, you mentioned codes. Are there any special enforcement risk raised by how these codes are communicated to the physicians?
Interestingly enough, there's a Supreme Court case called Alina versus Azar that said that you can't use for false claims purposes regulations, so to speak, that have not been subjected to the notice, comment, and response processes that are required by federal law. So the question becomes, since many of these codes are only described either in the preface to the physician fee schedule or in frequently asked questions or in MedLearn Matters articles that don't meet the standard of notice of proposed rulemaking, acceptance of comments, and response, we have an open question as to how these codes can be used in enforcement. That said, the OIG has already entered into substantial settlements. I mean, I'm talking $14.8 million kind of settlements for people who get it wrong. So the fact that we don't have a definitive answer today with regard to that doesn't mean that there's an open door for people to ignore all of this. I think it puts even more of a premium on getting it right in the first place.
Well, Alice, we appreciate you breaking this down as always for the audience. Can't thank you enough for the time and the insights.
Thank you, Mike.
And thank you to everyone out there for listening to this installment of Gosfield and Shay on health law. I'm hopeful that these insights into the non-face-to-face service traps and the evolving OIG red flags have helped you kind of navigate the high stakes of modern Medicare reimbursement. But if you need more guidance on compliance and fraud avoidance, do me a favor, visit gosfield.com right now to connect with Alice and the team. And one more favor before you go, hit like, hit subscribe, leave a review, comment, share the episode with someone who needs to hear it. I'm Mike Leon. We'll see everybody next time.
Thanks for watching. Be sure to hit that like and subscribe button and leave us a review in the comments.